Morning. So what we're going to do this morning, we're going to go over recognizing EKG changes that you may see or symptoms that you may see in athletes that may have predisposition or conditions that may predispose them to sudden cardiac death. I'm not going to go into detail about the controversy regarding should we be doing EKGs in athletes. That's another topic, and that would take a couple hours to go over that. If we go through it fast enough, if you have any questions regarding that, then we can probably address a few questions regarding that topic. I got no disclosures. So sudden cardiac death may date all the way back to 490 BC when Philippides ran the first marathon to announce the Nike, which was the victory of over ran from Sparta to Athens. So Philippides, as soon as he proceeded to announce the Nike, he died. So he's believed to be the first person to have had sudden cardiac death. So he ran the distance of a marathon. So that's where the statue of Philippides lies right now, and basically the victory over the Persians. The problem is, and as a society, what we're faced with is that anytime a young athlete dies, that's a big hit to us as society, it's a big hit to us as physicians, because we always ask the question, could we have done something to prevent that death? So here's normal EKG. And you know, when you read EKGs, you got your rate rhythm, your interval analysis, your axis hypertrophy, your QRST changes, and finally your interpretation. We know what normal findings are. Sinus rate between 60 and 100. We know about the P wave. I'm not going to go over details of that, because at this point we should know what a normal EKG looks like. Problem comes when we have an athlete coming to the office, we decide to do an EKG on them, and all of a sudden that's what the machine reads. And we have a healthy 35-year-old sitting in front of us here for a sports fit score, sports clearance, and that's what the machine reads to us, and we start looking at that EKG, and there are some changes there where it was raised some concerns. We got some left ventricular hypertrophy changes here. We've got some really tall peak T waves here in the anterolateral leads. We got all these inverted P wave. We got a little bit of maybe a bundle branch, a little RSR right here on these leads here. So the question becomes, is this abnormal, or is this normal in an athlete? So if we were looking at, I thought those would come at the end. So if we're looking at EKG findings in a trained athlete, which one would be an abnormal finding? So if we're looking at that, sinus bradycardia, a well-trained athlete, that would be present. I've seen athletes, ultramarathoners, triathletes with heart rates as low as the mid-30s, low 40s, when they come to the office. Even first-degree AV block could be normal. Incomplete bundles. However, left atrial enlargement would not be something that would be normal in an athletic EKG. So what's athletic heart? Just like any muscle in your body, if you go to the gym, start lifting weights, your muscles are going to change. So the same thing happens to the myocardium. You start exercising, and that muscle is going to generate some changes depending on the load that the athlete is generating. So those changes are going to increase consumption of oxygen, it's going to increase cardiac output, the stroke volume goes up, systolic blood pressure may be slightly increased, there's decrease in peripheral vascular resistance, and 50% of well-trained athletes will show some sort of cardiac remodeling. So when we're looking at the EKG in athletes, there are certain conditions where EKG may help us find those conditions that are increased risk. However, when we look at physicians that have an expertise in looking at EKG in athletes, we have a shortage. We have to admit that we're not well trained in reading athletic EKGs. Most sports medicine and cardiology training programs lack a good educational curriculum when it comes to EKG interpretation in athletes. However, the International Olympic Committee, the European Olympic Committee now require EKG as part of the sports physical. So if you take care of elite athletes, at some point you're going to have an athlete come in and you're going to be required to do an EKG. Currently also, all professional sports here in the United States require an EKG as part of the physical exam. NCAA Division I has also established a rule where they require an EKG as part of the pre-participation physical exam. So you're going to come across these EKGs at some point or another. We need to understand that there's a criteria that has come up in the last 4 or 5 years that helps us and aids us in interpreting these EKGs in athletes. So habitual exercise will cause an increase in volume of the chambers, wall thickness, but this is a symmetrical increase in wall thickness. It's a balanced remodeling throughout the heart, especially the ventricles. There's a balanced remodeling of the ventricles. There may be a genetic predisposition. So one thing that we have found is that athletes that have that ACE genotype have better remodeling of their heart, and there may be a genetic predisposition for those elite athletes, and for those athletes to undergo heart changes, we may predispose them to perform better at higher levels. Meanwhile, their systolic and diastolic functions are maintained. If we look at endurance sports, we have a significant increase in cardiac output, but not a significant increase in blood pressure. When we look at an athlete that's mostly involved in power sports, let's say a rower, there's a significant increase in the blood pressure, but very moderate increase in the cardiac output. If we have athletes that are in some sort of combined sport, there's increase in both. This picture here, and the important thing about this picture is here at the top we got the athletic heart, down here we got the diseased heart. The important thing about this picture is these arrows. Look at the fact that all these arrows right here are bidirectional, while these arrows just head one way. Diseased heart is not reversible, but meanwhile the athletic heart is. So one of the things that we would see in an athlete that stops exercising, they head to retirement, and they stop exercising at the level that they were before, their heart will decondition, but basically would just head back to normal. Meanwhile, in the diseased heart, once you have these disease conditions, that's an irreversible condition, irreversible change to the heart. When we're looking at echo changes in an athlete versus a non-athlete, we're also going to see in the echo some significant changes. We're going to see that the left ventricle and diastolic diameter may increase. The left ventricular wall thickness also increases, but this is again a symmetric increase in wall thickness. There's normal filling, normal ejection fraction, symmetrical enlargement of both the left and right ventricles, increasing the aortic root diameter, and some mild left atrial enlargement, but not significant. So the Seattle criteria, or the athletic heart EKG findings, this is basically the criteria that came out in 2012 to help us and guide us in looking at athletic EKGs. So if sinus bradycardia, 90% of athletes will have that. It basically is due to a predominance of the vagal tone. It's usually over 30 beats per minute without any symptoms. They may have a junctional escape rhythm. There may be a sinus arrhythmia, even a first and second degree Morbid's type 1 AV blocks, incomplete right bundles, early repolarization. You may have some PACs and PVCs, isolated LVH, and that's isolated LVH just by voltage criteria. There are no pathological changes in the EKG to point out at other issues, left ventricular strain, left atrial enlargement. Basically what we look at is just voltage criteria for LVH. In Black or African athletes, and the reason we calcified as that is because there are Hispanic athletes and there are athletes here from African countries. So in those athletes, there may be some convex ST changes on their anterolateral leads that may also be normal. However, in athletes that are non-Black, non-African American, those changes may be abnormal. So we have to be very careful when we're looking at that criteria. And I'll tell you that when I see that, even in a Black or African American athlete, I'm very careful with those findings, and I may have that athlete proceed with further testing. So here we have pericarditis. So again, usually over 30 beats per minute, or as low as 30. If it's under 30, may raise a few flags and maybe something that you may want to investigate. We have junctional escape rhythms, pointed here by the arrows. Those are also normal when we look at an athletic heart. Ectopic atrial rhythms, also a normal finding in an athletic heart. Sinus arrhythmias. I mean, of course, if we had a patient that came in with some disease issues or some medical problems, this would be abnormal, but completely normal in an athletic heart. First degree AV blocks with the increase in our PR interval. Second degree Morbid's type 1 AV blocks, where we have the increasing PR interval until basically at beat it's dropped. Incomplete right bundles. Early repolarization. And this is basically the classic definition of here, early repolarization. These are now some of the new definitions when it comes to early repolarization, and those are the things that also we'll see in athletes, and we gotta be aware of. Again, as isolated LVH, so if you look at this EKG right here, pretty much other than the voltage criteria for LVH, and we got here the S on R findings, but when you look at this EKG, there's no strain, there's no bundled branches, there's no lateral enlargement when you're looking here. So it's all basically just isolated voltage criteria LVH. And again, and this is a set of slides here to show you LVH from an athlete to just voltage versus pathological LVH. So here you can see there's the strain, the ST changes, T wave inversions. You have left atrial enlargement, where you can see here in lead 2, also looking at lead 1, you can see the deep P wave here, the biphasic P wave with the terminal P inverted. So those are now pathological changes due to LVH. These are the findings that we can see in Black or African American athletes. And again, while this may be normal in this population, they're quite abnormal in other populations. So this is a finding that I would be very careful regardless of the ethnicity or the background of the athlete, and I would probably err on the side of caution and have this further investigated before clearing the athlete for further sports. So one of the things that you will find is whenever we're seeing these T wave inversions here in the anterolateral leads, especially when we get to V5 and V6, that's something that's going to raise some flags. So we have ethnicity, age, gender, the discipline, the level of training, all those things can affect the EKG changes. We discussed some of those before. This is the latest reference regarding all those EKG findings in athletes. So here's an EKG on an athletic heart. Again, what we have here is the early repolarization changes, some peak T wave, LVH, early repolarization changes again here. So these are all normal changes in an athletic heart. So the question becomes, do these changes have a long-term health impact on sporting performance? There was a thought at some point that maybe these EKG changes led to sudden cardiac death or increased the risk of de novo sudden cardiac death. And what we have found is that there's no long-term disease progression in athletes that undergo all these changes. And as I said before, all these changes are reversible, so usually as the athlete decreases their amount of activity or the amount of performance, these changes are going to be reversible and the heart will lead back into normal electrical function. So meanwhile, say we have a 22-year-old black American athlete collapses and dies suddenly during a college basketball game, had a sports physical done prior to his Division I college athletics, was normal, no cardiac problems. He's tall, about 6'9", no recent illnesses, was not taking any medications. His grandfather, who was also tall, died of some heart problems in his late 60s. Which of the following is the most likely cause of death? How many think would be coronary anomalies? How many would think would be hypertrophic cardiomyopathy? A few more hands there. How about myocarditis? Aortic dissection? Hands here, arrhythmogenic right ventricular dysplasia. So when we're looking at the United States, when we're looking at a question like this, we've got to look at its prevalence. What's the most common cause of sudden cardiac death in athletes in the United States? And that's hypertrophic cardiomyopathy. So while they try to confuse you there in the question, we gave you some history of maybe this is Marfan, which make you think about aortic root dilation. You got to look at what's common, and what's common is hypertrophic cardiomyopathy. ARVD, the last answer in that question, is actually the most common cause of sudden cardiac death in the world and in Europe. And that's where some of the controversy starts when it comes to should we be doing EKGs in all of our athletes. So there's about 10.7 million participants under the age of 40 in amateur and competitive sports in the United States. The prevalence of cardiovascular disorders known to cause sudden cardiac death in these athletes is about 0.3%, about 3 in 1,000. If we look at the incidence yearly of sudden cardiac death, it's about 1 in 134,000 per year in males, 1 in 750,000 per year in females, 1 in 50,000 race finishers, and it accounts for about 300 deaths per year. Quite a few. But when we're looking at incidence of disease, and then we're looking at how many participants are there, again, this is another one of those areas where we go, well, if we did EKGs on everybody that was participating in sports, 10.7 million people under the age of 40, when we have such a low incidence of disease, let's say 131 to 134,000, if you had a very sensitive test at 95%, you will run into a high degree of false positives. Do we have enough cardiologists to go around to look at all those abnormal EKGs and all those athletes? So that's where, again, one of the arguments against performing EKGs in all athletes. If the incidence of disease was much, much lower, say in Black and African American basketball players where the incidence of cardiac death is as low as 1 in 13,000, then it would make a little more sense to screen those athletes. So what we're looking at now when we're looking at EKGs in the general population, we're looking at subgroups. And the argument now has become that instead of advocating to screen everybody, maybe we should focus on certain groups that are the groups at high risk, because those would be the ones that would benefit the most from the screening with the EKG. So this is from 1996, and this data hasn't changed much since then. We're looking at the sports time of death. Basketball by far is leading cause, followed by football. So again, this is one of the things what we're looking at. Since these are the sports where we have the highest sudden cardiac death issues, we're focusing more maybe on those sports and certain populations within those sports when we maybe start thinking about screening them or including the EKG as part of their physical examination. So when it comes to sudden cardiac death, and we're looking at the causes in the US, again, hypertrophic cardiomyopathy, about 45%. So by far the most common cause of sudden cardiac death in athletes here in the States. Unfortunately, the second most common cause is coronary anomalies. And I say unfortunately because even if we did EKGs, we're not going to find those. So even if we include EKGs as part of the screening physical exam, we may still miss about 20% of those people. Myocarditis accounts for about 10%, and certainly that is something that it's preventable because we should be able to diagnose that, and we should be able to, when we look at the history of the athlete or we're interviewing the athlete, be able to pick those out. Rupture aortic dissection, those usually are people with Marfan's. Aortic stenosis, dilated cardiomyopathy, idiopathic myocardial scarring. ARVD is only about 3% here in the States, while it's the most common cause in in Europe and the world. And the others are 9%. And the funny thing is about those others are usually the ones that we get asked about on our tests. Because when we're looking at those other causes, that's usually the Brugada syndromes, the Marfans, the WPWs, the heart blocks, prolonged QT, short QT. Those are the EKGs that we usually see on tests. They put a WPW kit, they put a prolonged QT, a short QT, and those are the ones, because those are the ones that are easy to recognize on an EKG. The other ones are much, much harder to recognize on an EKG. So we're looking at sudden cardiac death in athletes in under 35 years old. Again, hypertrophic cardiomyopathy, almost about 50% of those athletes. When we're looking at athletes over 35 years of age, it's actually coronary heart disease. So a completely different population when it comes down to what the cause of sudden cardiac death is. So again, we should be able to identify these through history, physical exam. Certainly we're looking at someone that has hypertension, diabetes, multiple risk factors, wants to start exercising. We got to start thinking about, should we do a stress test before they start participating in high intensity or moderate intensity exercises? And there are certain criteria regarding that as recommended by the American Medical Society of Sports Medicine. So next question, you have a 15-year-old girl comes to your office for a sports physical. During the review, you discover she has a family history of what appears to be sudden cardiac death in a paternal uncle and her paternal grandfather. Her physical exam is normal. You decide to perform an EKG. Which EKG finding in this patient will place her at higher risk for sudden cardiac death? How about a QT interval of over 490 milliseconds? How about an inverted T wave in AVR? A fixed PR interval of 0.23 seconds, a heart rate of 51 beats per minute. So if we look back at the Seattle criteria that we discussed before, let's start down here. Heart rate of 51 beats per minute. We know that sinus bradycardia is normal in athletes. A PR interval is slightly above normal. First degree block can be also normal in athletes. An inverted T wave in AVR is pretty much a normal EKG finding. But this QT interval is prolonged. So she's got QT interval prolongation. So again, remember, QT prolongation can be familial. And in most cases of sudden cardiac death, it is familial. So you got to look at the history. So not because you have this history are you going to think only hypertrophic cardiomyopathy. You got to start thinking of other diseases that can be hereditary that may lead into sudden cardiac death. So a QTC over 440 milliseconds is considered abnormal. Okay? So what are the abnormal findings in athletes? And this is again based on the Seattle criteria. And the way the Seattle criteria was developed, it was over the course of many years, they did EKGs in athletes. And they basically looked at what were the common findings in athletic heart. And then the ones that were not very common were classified here. So even though they may not lead to sudden cardiac death, they are rare in athletes, and in some instances has been associated with sudden cardiac death, so that's where this list comes from. So these are rare findings in athletes. So while they may be normal, they're certainly not common and may put the athlete at risk. So we look at T wave inversions over 1 millimeter in 2 or more leads. We look at ST segment depressions, pathological Q wave, complete left bundle branch blocks, a QRS over 140 milliseconds, left axis deviation, left atrial enlargement, right ventricular hypertrophy pattern, of course our WPW, the ventricular pre-excitation, the long QT interval, and when we look at numbers, those numbers are not the American Heart Association or the American College of Cardiology numbers, which are usually 440 and 460. Okay? So when we look at athletes, it's a little more, again, because we looked at hundreds and thousands of EKGs in athletes, what we found is that athletes do have a slight prolongation of their QT interval, which is normal. But once it starts going above those numbers, it puts them at higher risk and becomes abnormal. Okay? Short QT interval or under 320 milliseconds, a Brugada-like EKG pattern, second degree Morbus type 2 or a third degree AV block, profound sinus bradycardia under 30 beats per minute, or a sinus pulse over 3 seconds. Again, could this be normal in an athlete? It can be, but it's very rare to find that, so it probably should pursue that a little further. Atrial tachyarrhythmia, anything like SVT, AFib, A-flutter, over 2 PVCs in a 10-second tracing. So you got more than 2 PVCs in your EKG. That probably should get a further consideration and further investigation, because remember, as that athlete exercises, if that amount of PVCs goes up as the heart rate goes up, you could be easily looking at over 200 to 250 PVCs in a minute once they start going and they start exercising, which could put them at a high risk for ventricular tachyarrhythmia. And then ventricular arrhythmia is the last one there. So say you have a 26-year-old basketball player with exertional syncope. So this presents to your office. I was playing basketball. I've been feeling tired, and one day I collapsed playing basketball. Certainly, in that history, you got tons of red flags. And I would tell you that rarely do you have that present to your office. Because usually what will happen is the athlete will collapse while playing and die. Or if they're lucky enough to survive, now they're being seen in the hospital because they had basically ventricular fibrillation or ventricular tachycardia, they were shocked, resuscitated, and now they're in the hospital. So it's rare for you to have a clean history or a clear history like this. Well, say you get one, and you get a 26-year-old basketball player with exertional syncope comes in, and you decide to do an EKG, and this is what you see. So is this athletic, or is this at risk for sudden cardiac death? So what do we see here? Well, we certainly see voltage criteria for LVH, okay? Pretty much all the way throughout. No significant Q waves through here, no PR interval changes, no QRS enlargement, But look at all these inverted large T wave all the way throughout the anterolateral leads. This is one of the findings that we would find in hypertrophic cardiomyopathy. So it can be sporadic, but it's mostly inherited, autosomal dominant. The prevalence in adults is about 1 in 500. It's quite prevalent. But when we look at the incidence of sudden cardiac death, we go back and go, wait, you mentioned before, it was 1 in 134,000 in males, 1 in 175,000 in females. With such a high prevalent disease, how come we don't have more sudden cardiac deaths? Because not everybody that has HOCMs is exercising, and not everybody that has HOCMs has that episode of sudden cardiac death. In comparison to athletes, it's about 1 in 1,000 to 1 in 1,500, so it's, again, quite prevalent. Typically may develop in early adolescence through young adulthood. You may have LVH, which is asymmetrical. Again, the LVH we see in athletic heart is symmetrical. Here is an asymmetrical septal hypertrophy. You may have also apical hypertrophy, or sometimes concentric. The problem with apical hypertrophy is that it's difficult to see with an echocardiogram. So one of the things we're doing these days, if we suspect an athlete of having HOCMs, we actually do a cardiac MRI, which will actually give us a better idea of that, what that septum looks like, what that apex looks like. They may have diastolic dysfunction, and essentially what the is is a dynamic left ventricular outflow tract obstruction. So you have a septum that's enlarged and basically blocks the outflow of blood through the aorta as it exits at the left ventricle. So one of the things that what we look for is murmurs. So one of the things that we do when we're doing sports physicals, we have to do maneuvers. You can't just listen there like you do in a regular physical exam and just auscultate the heart and say, it sounds good. Part of the physical examination in the sports physical is to listen to the heart with cardiac maneuvers. So you have to have the athlete squat and stand, or lie down and stand, and you have to have the athlete do Valsalva maneuvers. Because what we're looking at is anytime we decrease venous return, so now the left ventricle has a lower preload, the murmur is going to get louder because that outflow obstruction gets narrower. Meanwhile, as we say, we go from standing to squatting and I increase my preload, my ventricle now gets more blood into it, increased preload, my outflow obstruction gets a little wider so the murmur gets softer. So those are the things we're going to look at when we're looking at maneuvers, when we're listening to the heart in the pre-participation physical exam. So here's a person that had hypertrophic cardiomyopathy. Again, here's the left ventricle, and there's this significant septal hypertrophy. Here, again, it can be apical, and essentially what happens is the athletes, because of all this hypertrophy, not only do they have obstruction of the outflow, which can compromise blood flow to the coronaries at increased rates, but also that can lead to arrhythmias, ventricular fibrillation, ventricular tachycardia, which then leads to sudden cardiac death. So if the athlete has symptoms, and again, they're lucky if they do, because then you may be able to catch them, they may have dyspnea, chest pain, exertional syncope, exertional presyncope, fatigue, palpitations, or exercise tolerance. Only about 21% of them have symptoms. So again, most of them, the presentation is they vent. If you do the exam, again, I talked about this earlier, you have that crescendo, decrescendo systolic murmur in the lower left external border that increases with Valsalva or standing from a squatting position. So again, both of those maneuvers, what they do is they decrease preload, which increases the sound of the outflow obstruction. If you have an athlete that you suspect having this, or you have to do a chest X-ray, EKG, and echo, and again, we're usually doing a lot of cardiac MRIs now because we're looking for that apical hypertrophy. What we're looking for is a left ventricular wall thickness that's over 16 millimeters. If you look back at the Seattle criteria from before, normal, we usually look at 9 to 12, maybe 9 to 13 increase in diameter, symmetrical increase in diameter of the ventricle. Here it's usually over 16. 13 to 15 becomes that gray zone. The treatment for this essentially is beta blockers. They may need an ICD. We don't do a lot of septal artery ethanol ablations anymore. That was an old treatment. That's usually not done these days. We usually do ICD and beta blockers. And actually, the biggest thing to do is they got to be excluded from all sports except low-intensity sports. (90 to 95) have an abnormal EKG, so a good argument for doing the EKGs. Again, if you have the right population, if you're choosing the right group of athletes where there will be a high prevalence and incidence of disease, you may be able to pick this up, because about 90 to 95% have a normal EKG. Things that you look for: left axis deviation, left atrial enlargement, abnormal ST segments, again that flick T waves in the lateral and inferior lateral leads, ST segment depressions. In the QRS complex, you may have LVH, tall R apical leads, deep Q waves laterally, or conduction delays. You don't have to have all of this in the EKG. It may just be one of them. It may be a couple of them. So you gotta have a keen eye to try to find those. For example, in this athlete, again, we have this inverted T wave. There's some left ventricular hypertrophy criteria here, but again, we don't have those Q waves and none of the other findings that we had before. Here's another one that has the ST segment changes, again with the deep T waves in the inferior lateral leads. Here we have one that, while we don't have those T wave changes, we still have the ventricular hypertrophy, and now we have these deep Q waves present, which make this EKG abnormal, and again, significant findings for hypertrophic cardiomyopathies. It could be a combination of symptoms, maybe one of the signs, it could be one of the findings, so you don't have to have all of them present for the diagnosis. So let's look at this next athlete here. You have a 17-year-old male that collapsed while playing basketball, and here we have his EKG. And first thing I look at when I'm looking at athletic EKGs, I look at those T waves. Inverted, inverted, inverted. So again, that starts raising flags in my head. This does not look like a normal EKG in an athletic heart. So this is ARVD, the most common cause of sudden cardiac death in the world and Europe. Basically what happens is right ventricle becomes fibrotic and doesn't develop well. And again, this leads eventually to arrhythmias and ventricular arrhythmia. It is familial, inherited, prevalence about 1 in 2,000 to 1 in 5,000. It can be acquired with intense endurance sports. Again, this is a progressive dilation, dysfunction of the right ventricle. So again, looking back at that EKG, main thing I will point here is, again, very little, look at the voltage, very small voltage, and then this inverted T wave all the way throughout the anterior lateral leads. So basically you have a right ventricular muscle that's replaced by fatty and fibrous tissue. You develop right ventricular arrhythmias, and eventually this leads to right and biventricular heart failure. About 68% of them have symptoms. Again, quite a few don't have any symptoms. So if they have symptoms, again, typical symptoms that we would see in someone that has an intolerance to exercise or a heart issue. Their physical exam is normal. There's no murmur you can listen to. There's no physical exam finding when you listen to them. If you have an athlete where you suspect this, you can do an EKG and echo, Holter monitoring, stress test, ventricular angiography. And again, the treatment for this is they gotta be excluded from all competitive sports and they need an ICD. 80% have abnormal findings. And again, these are some of the EKG findings. So and in the previous example, we had those inverted T wave. The EKG that I showed didn't have these epsilon waves, and I have the next EKG that I show you has those. And then you got all that low voltage in the limb leads. Again, you don't have to have all these findings. A few of them will be enough. This is what the epsilon wave looks like if you have one. If you ever see one on a test, this is probably the one they're going to give you so you can identify the epsilon wave. So it's a discrete deflection at the terminal portion of the QRX complex, usually in V1 to V3, and inverted T wave in the anterior leads. So here, that little terminal portion right there, that's our epsilon wave, and that's very typical of ARVD. Again, some of the next subtle changes. Again, we got all this small voltage criteria, inverted T wave, the slur here on the ST change, also findings of ARVD. These look like PVCs. They're actually not PVCs. There's actually another change that you can see in ARVD. So you got to be very careful when you're looking at EKGs in this population. So you have a 23-year-old triathlete presents with a 3-week history of progressive fatigue, exercise intolerance after a fluid illness. Evaluation leads you to make a diagnosis of viral myocarditis according to the 36 Bethesda guidelines, and these are the guidelines that are evidence-based that make recommendations regarding participation in sports based on what cardiac condition you have. So if you're doing sports clearances, if you're doing pre-participation physical exams, and you find an athlete with a heart condition, you got to refer to these guidelines to basically base your decision regarding limitation and restriction in sports. So you recommend that he not participate in competitive sports training and rest for approximately what length of time? So after you diagnose someone with viral myocarditis, how long should they stay out of sports? A month, 3 months, 6 months, or they should never go back to sports? So 6 months. So if you're looking at the Bethesda guidelines, which are basically based on consensus and expert opinion, they recommend athletes with myocarditis may return to training and competition after a 6-month period if the ventricular function, wall motion, and cardiac dimensions return to normal on an echocardiogram, no arrhythmias are present on a Holter monitoring and graded exercise testing. 3, 0 markers of inflammation or heart failure have normalized, so essentially got to get CKs, troponins, and make sure that everything's gone back to normal. And then you do a 12-lead EKG, and that looks normal. So wait 6 months, meet all these criteria, you can go back to sports. So again, 3rd common cause of sudden cardiac death in the United States, about 10% of athletes, certainly preventable, diagnose it, make the right recommendations regarding return to play. 14-year-old with shortness of breath, fatigue while exercising, was recently sick, has been running fevers and vomiting. Again, I look out here, I see these T-wave changes. Certainly the history doesn't look real well. She's been recently sick, she's been running fevers, shortness of breath. So what would this one be? Prior one had myocarditis, this one has. So these are the changes to myocarditis. So these fused T-wave inversions, again, look at all these T-waves. Again, look out here, T-wave inversions all the way throughout. Okay, incomplete atrioventricular conduction blocks. Okay, so 6 months, and then back to sports once they clear all these EKG changes, once they clear their cardiac enzymes. So inflammatory condition, infectious origins, usually Coxsackie B virus accounts for over 50% of cases. They have flu-like illness, dyspnea, orthopnea, cough, chest discomfort, exercise intolerance. Again, we're looking at the history. They've been sick. They may still be having issues. Now they're having trouble exercising. They're feeling short of breath, chest pain. If you do a chest X-ray, EKG, or echo, or a cardiac MRI, suggests a disease. Elevated cardiac markers. You don't really need to do a myocardial biopsy to confirm it. Okay? Pretty much based on the history, physical, EKG findings, and your labs, you can make the diagnosis. So there's really no need to do confirm by biopsy. 18-year-old male collapsed while playing basketball. Again, I mean, sometimes I get these kids. They were playing basketball, and then you start wondering, was this heart related? Was this seizure? What happened? But then you do an EKG, and this is what you find. What's wrong here? Sinus rhythm. Rate looks normal. Long QT. Look at how long this interval is. So, can't miss this. You gotta see this. Long QT syndrome, prevalence about 1 in 2,000. Usually inherited mutations in cardiac ion channel protein genes. Up to 30% of gene carriers may have a normal QT. Essentially, stress-mediated ventricular arrhythmia is called syncope and cardiac arrest. Basically, you have to look at the family history. If they are lucky enough to present with some sort of symptoms, you may be able to diagnose them. And again, when we're looking at QTC, it's over 418 women and children less than 15 years of age, and 470 men, and this is the Seattle criteria right here. Okay. The treatment is basically exclusion from high intensity sports. And again, this is all based on the Bethesda guidelines. How about this one? 90-year-old female feels faint and dizzy while exercising. How about the QT interval in this one? Very short. So this is short QT. So under 320 milliseconds, prevalence 1 in 10,000. They have syncope, they have palpitations, ECG, and again, I didn't put it there, but these are also excluded from high-intensity sports. How about this one? 15-year-old female feeling palpitations, dizziness on exertion. There's a little bit of RSR here, some inverted deep T waves here, a little bit of hypertrophy. It looks like a little bit of widening of the QRS. Maybe the PR interval looks a little short. What would this be? So you have a short PR interval and a prolonged QT, a prolonged QRS. So widened QRS, short PR interval, WPW. Okay, and this is the classic, those are the things that they're going to ask you. WPW, short PR interval, QRS prolongation. Those are the classic findings. And of course, the delta wave. So if you look here, here's that delta wave, that short PR, and then this little slur here, which is what's making the QRS widen. Prevalence 1 in 1,000 athletes, about 1%, so very uncommon when it comes to sudden cardiac death, but again, this is usually one that we get asked about in tests. Delta wave, short PR interval, widened QRS. You may have a pseudoinfarction pattern inferiorly. Again, this is our delta wave. So the treatment for this essentially is you got to do a stress test, you got to do an EP study, and based on what you find on those studies is where you're going to determine whether this person is going to need an ablation or not. And usually pretty much if there is an athlete that needs an ablation and undergoes the ablation, they're usually cleared to go back to sports. They usually undergo another stress test, another EP study, make sure there's no further abnormalities, and once they go through that and everything is okay, they can go back and resume full activities and participation in sports. Now you have a 17-year-old collapsed while playing football, mother states he kind of breathes funny at night. So looking at this one here, sinus rhythm, good PR interval, QRS complex doesn't look prolonged, QT interval looks okay, but when we're looking at this, look at this QRS with this tall S wave here, and then this looks like a ski slope coming down to this inverted T wave. That's the abnormal finding here. And this is what we usually see in people that have Brugada Syndrome. This is a sodium channelopathy, autosomal dominant inheritance, about 5 to 66 per 10,000 with a male predominance. 4% of all sudden cardiac death in the general population. And then you have that ST sapien elevation with polymorphic VTAC as sudden cardiac death. So usually what we're looking, and usually these people don't die exercising. Usually die while they sleep. So they have a funny breathing pattern. It's almost like an apneic pattern when they're sleeping. So this is one of those people, these conditions that we're not actually looking at sudden cardiac death when they are exercising, but usually happens when they're sleeping. So these are some of the patterns related to Brugada syndrome. I would tell you the more common one that they're going to ask you about is this one right here. So usually we're looking at this pattern right here. Again, this is that diagnostic type with this tall S wave here, and then the kind of the ski slope to the inverted T wave. These here are the other types that you could see in Brugada syndrome, but usually these are not associated with sudden cardiac death. The one that's associated with sudden cardiac death is this one here. And the treatment for this is restriction from all competitive sports. They need an ICD only if symptomatic. They need to be referred to an electrophysiologist. Got a 24-year-old female, recently got over a cold. She's complaining of chest pain, washed with exercise. Key thing you got to look at here is look at all those peak T waves all the way throughout, ST segment elevations all the way throughout. So what's this one? Not myocarditis, we already talked about that one. This is the other itis, pericarditis. Okay. Another one, if you look at the history, this one you should pick up. So they may have recent illness, chest discomfort, a friction rub on the exam. They may have elevated cardiac enzymes. The treatment essentially is NSAIDs for 3 to 4 days. You can add steroids if they don't respond for 48 hours. Basically, they can return to play after they have no longer evidence of active disease. So you got to have, again, normalization of serum markers, normal EKG, normal echo. Oh, this one, 20-year-old cyclist with irregular heartbeat, otherwise asymptomatic. We talked about the shadow criteria before. What shadow criteria presents itself here? How many PVCs are on there? 2. So 2 PVCs or more in a 10-second strip should prompt further investigation, further workup. Because individual may have over 2,000 PVCs per day. This can lead to ventricular arrhythmias. So basically, these individuals get a Holter monitor, they get an echo, they get a stress test, and we're trying to find is, do these PVCs multiply and become more frequent as they exercise, or they just disappear and everything normalizes? So this is just one of those things you guys do a little bit more workup when you have an athlete that presents with those findings. Okay, when it comes to coronary anomalies, 33% may have symptoms of exertional syncope or exertional chest pain. Again, the exam on these people are going to be normal. This is our second most common cause of sudden cardiac death. EKG looks normal unless they've had an MI, a Q wave. They have Q waves present because of an infarction before. Echo can identify about 95% of these. The diagnosis is really made by angiography or cardiac MRI or CT angiography. The treatment will be immediate exclusion from all participation in competitive sports. They may need surgical intervention to fix the coronary anomaly. Once the coronary anomaly is fixed, they may be cleared for sports by their cardiologist and their surgeon if they feel comfortable enough that the correction of the anomaly it's good enough that they can return to sports. And actually have a kid in the high school football team that I covered who had a coronary anomaly, and it's actually an interesting story because he collapsed 3 times exercising and playing sports before someone thought about sending him to a cardiologist. So quite a lucky kid. So after the 3rd time when he collapsed, someone said, maybe we need to send you to a cardiologist, and that's when they found he had an anomalous coronary. He's undergone surgery. He's about 1.5 years out from surgery. He's doing well, and now he's participating in football. So this is an anomalous origin of the left here, and this is the anomalous origin of the right. Well, this is normal, and essentially, if you think about it, basically what happens is as your heart rate goes up and the heart starts beating faster, the coronary arteries start compressed. So eventually, as the coronary starts getting compressed, you compromise coronary flow, leading to myocardial infarction or arrhythmias. Marfan syndrome is, I think, the last thing we're going to talk about. So autosomal dominant connective tissue disorder, incidence about 1 in 10,000 people. They get a progressive dilatation of the aortic root. Dilatation results in cystic medial necrosis. 50% are undiagnosed and die by age 40. If you have any suspicion, you may have to do genetic testing or look at family history for sudden cardiac death. Finding suggestive of Marfan's, you got to look at family history. Do they have a mid-systolic click, a heart murmur, and then basically the other physical findings. Do they have kyphoscoliosis? Do they have pectoral scavatum? Arm span significantly greater than height. So you look at the arm span versus their height. Do they have a long, thin face? Do they have myopia or an ectopic lens? Do they have hyperextensible joints? Upper and lower body ratio more than 1 standard deviation below the mean. One thing that you can check for, and you guys can do this, try to overlap your thumb and your pinky around your wrist. So just if you wrap your thumb and pinky around your wrist, you'll see that most of you can't even get them close to each other. People with Marfan's overlap them. Okay? Another thing you can look at is if you put your thumb inside your hand like this, you can't see my thumb. People with Marfan's, the thumb will stick out the bottom of the hand as they put it across. So those are some of the physical findings, some of the things you can look at when you're trying to see if someone may have Marfan's syndrome. So these people get an echo every 6 months. That's just restricted cardiomyopathy, so I'm going to skip over that. Okay, so last question. You're covering a high school baseball district final. One of the players, while batting, is hit by a fastball in the middle of the chest. Takes a few steps towards first base, collapses to the ground unresponsive. Although he appears to have some mild seizure-like activity, this child is previously healthy, has no known medical problems. Which of the following is your response? You treat him for a seizure and administer Ativan immediately. You activate the emergency response system, start CPR, and place an AED on his chest, administering a shock if so advised. You call 911 and wait for the ambulance. You suspect the rib fracture causing a tension pneumothorax and prepare to do a needle decompression. What do you think? Vote for A, vote for B, vote for B. This is pre-contusions which can lead to sudden cardiac death due to an arrhythmia. If the ball happens to hit right on the T wave, then you get ventricular arrhythmias set basically by the jolt of the hit. Remember, remember we do a chest pound, right, sometimes to try to get someone out of VTAC or VFib. Well, this is one that induces VTAC or VFib by pounding the chest, basically, and creating 2 to 3 joules of energy from the impact. So if you're covering sports, if you're ever in a field or something, know where your AED's at, because AEDs will save lives, especially when it comes to this kind of condition, this kind of impact. So one of the things that I tell my residents, my fellows, there's got to be an AED on the sidelines before we start this game. Because if something were to happen out there and I need to put an AED on someone, it's going to be right there. Okay. So what an AED is, evidence shows that the best chance of survival in case of cardiac death is having rapid access to the fibrillation emergency action plan. If the sudden cardiac arrest occurred in a high school setting, 64% survived to hospital discharge. It was an AED on site. Only 11% if you called EMS and waited for EMS to show up. The American Heart Association recommends that every school that cannot achieve an EMS call to shock time in less than 5 minutes have an AED on site. Many athletic and medical research recommend that schools have access to an AED with a goal of less than 3 to 5 minutes from collapse to shock. Thank you.
Thank you, Joe. So you referred to low impact sports when you let your athletes return. Do you mean like athletic endeavors that don't raise your heart rate? Would that be low impact?
When we look at sports, we classify them from low intensity to high intensity sports.
Walking?
Walking would be low intensity.
Okay.
Playing golf would be low intensity.
No tennis?
Bowling.
No tennis?
Would be low intensity. Tennis singles is considered high intensity. Tennis doubles is moderate, so no tennis.
Okay.
Right.
Thank you.
Yeah. So.
Contact sports.
Well, most contact sports are high-intensity sports. So
Do they have a special category? High or
no, they're usually in the high-intensity categories, like football is on the high-intensity category, hockey's on the high. So we're looking at mostly cardiovascular load and basically the rising cardiovascular need
Heart rate.
based on the exercise. So that's what we go from. Low-intensity sport is anything that's usually under 4 mets
Okay.
of intensity. Moderate is over 6. Anything over 10 becomes a high-intensity exercise.
My associate was a cardiologist, and he got a number of professional athletes. And if you talk about scary EKGs, we would look at these and go, oh my God, what are we going to do? And I'm glad our knowledge has progressed. We saw one guy, and he showed me the chest x-ray, and everybody assumes because they're athletes, they're healthy. You know, and the school physical was sort of a pat on the fanny. It was really very incomplete. I think we're taking it more seriously now for these reasons, which is great for this presentation. One of the pictures he showed me, a guy that played for the Pistons had an atrial septal defect, and you can see the huge pulmonary arteries going out. So just because these people are supposed to be healthy doesn't mean they don't have issues. When this guy got his ventricle his atrium patched, he went back and played another 10 years for the Pistons. So just because we think they're healthy,
Absolutely.
I think a lot more proactive now for what we can fix.
I've been fortunate to help sometimes Dr. Riley with the Rays during the spring training physicals. And part of baseball, in the spring physicals, everyone gets an EKG. It's rare to come across a normal EKG. Pretty much over 90% of the EKGs we come across have athletic heart changes. So if you look at the reading on the machine, and the machine is spitting out MI or spitting out ventricular hypertrophy, acute MI, and you're looking at those going, no,
Worse
no,
than
no.
LVH, it'll say MI.
Yeah, and then you gotta look through it and go, no, these are all athletic heart changes. I mean, and we also have a cardiologist there during those exams, and he's actually also looking at the EKG. And I do another lecture where I look at the reading of EKGs in athletes as part of my lecture on should we or should we not be doing EKGs as part of the sports physical. And there was a study done where they actually gave abnormal EKGs to a group of cardiologists before giving them the shadow criteria. And all they told them was, just say normal, abnormal, can play sports, cannot, and should not play sports. Only about 80% of the time were they correct in the clear, not cleared. And they had about 25% error in can participate or not. And so they restricted athletes that shouldn't have been restricted, and they didn't restrict athletes that shouldn't have been restricted. Even when they make the right diagnosis, they would still clear them. So there's a big gap of knowledge
Once
when it
again,
comes to
pointing out
athletic EKG.
the need for education, which
Yes.
thank you very much for this elegant and excellent presentation.
Any other questions? Yes, we got one.
I have to deal with a number of obesity patients, and I usually favor the low-impact exercise approach. I like to go with a pulse measurement every 30 to 60 minutes to see how they're doing on intensity. Is that an appropriate
Dr. Rogers, could you repeat the question just?
They're asking about, say a person that's starting a sports regimen,
and is obese?
and it's obese, what's a good way of determining are they doing it right, or a way to monitor their heart rate, or monitor their activity? So, I mean, the first thing I look at is if I have someone that is wanting to try and start exercising, say someone that's sedentary, say in this case obese, first thing I'm going to look at is what are the risk factors that they have for heart disease, especially if it's someone over 35 where coronary artery disease is the more common one. I'm going to look at what are the risk factors for coronary artery disease, and then the next thing I'm going to look at is what intensity sports are we talking about? Because if you have someone that has 2 or more risk factors or a coronary equivalent, and once it's and say a male over the age of 55, a female over the age of 60 who wants to engage in moderate to high intensity exercise, they need a stress test before I clear them. If they don't have any risk factors, say they're only obese, no other risk factors, no coronary equivalent, and they want to engage in low intensity or moderate intensity exercise, you don't need a stress test. And what I would counsel them on, start with a low intensity exercise, such as say walking, then we'll progress to maybe jogging, or maybe in the case of a obese patient, walking or running may be hard, a bike or an elliptical machine. And then basically what I want you to do is monitor your heart rate. It's kind of the theory behind Orange theory. You're looking at your heart rate. So what you want to do is increase your heart rate to usually about 70% of your maximum heart rate, and you want to maintain it there. At the beginning, I would say do it in intervals. So for a minute or so, slow down, bring it back down. After a minute or so, try to bring it back up. Eventually, as they continue to exercise, they'll be able to develop a little more stamina and maintain the heart rate in that 70 to 80% range for longer periods of time. If the heart rate starts going above that 80% intensity, I certainly tell them you need to slow down, bring it back down. And the goal is to have, if you look at the American Heart Association recommendations, 150 minutes per week of cardiovascular exercise at an intensity that your heart rate is raised between that 70 to 80%. So that's the goal. So eventually it's just trying to get your patient there, but always before clearing them, again, I look at what sport are you talking about, and then I look at what are your risks, especially in that over 35 group.